And just to orient here before I hand it over to CACP around, what is it that, what is our shared focus for today's conversation, increasing access to services and addressing challenges in behavioral health for adolescents with an emphasis on upstream solutions and crisis prevention. So, seems simple, but a lot of work has gone into really honing us and getting us aligned on that focus, and really, really excited for how our collective effort can move the needle in service of improved outcomes for communities that need it most. So with that, I'll hand it over to Team CACP to lead us through some of the findings.
Great. Thank you so much, Eamon. And the feeling is quite mutual in terms of working with you all as well on this project. I'm going to turn things over to my colleague Heidi Aylward in a second to actually go through our initial findings. But just a brief overview. Our role in this work has been and continues to be around how we integrate the voice of direct Medicaid beneficiaries and the communities that serve them to start with us from ground zero in defining what the barriers are, identifying their challenges, and figuring out what the opportunities and what the solutions might be that will really work for them. In our work at CACP, we have historically found that the missing link to success with innovation is often not having connected directly with those who are going to be using care and services at the end of the day, because those individuals know better than any of us what their challenges and what their barriers are. So that was sort of from an overarching perspective, that's our objective with this work, is to elevate those voices and bring them to the table early and often as the rest of this work progresses. I will say we are still in the middle of this work. We are not done yet. So the report that you're going to hear Heidi deliver today is the set of themes that we have discovered so far. I actually think that we have that we've probably uncovered most, if not all, of the key themes to this point in our work. The goal going forward will be to just deepen and sharpen those insights for the next few weeks as we continue to reach out to talk with beneficiaries and the communities that serve them. But with nothing further, I'm going to turn it over to Heidi and have her share what we've learned so far from the communities that you all are serving in both Arizona and West Virginia. Heidi?
Great. Thank you. Thank you, Melinda. Thank you, everyone. Just to briefly touch on the methodology that was used to capture the voice of consumers. With the help of all of you, we had some initial introductions that were done, and we did a round of interviews with some key community stakeholders that were recommended to us by you, and ultimately worked down through community-based organizations in both states. That included talking with providers, and then ultimately with beneficiaries. And beneficiaries included some teenagers, and in some instances, their family members or their caregivers or parents. So we can go on to the next slide. I'm going to take you through each of these key themes that we identified throughout this work in more detail in a moment. We'll walk through one slide that will describe each of these insights for you. On the left, it is really us synthesizing what that barrier is. On the right is what that sounds like in the voice of the consumers. Before I go into the detail, though, on the next slide, I just want to, as a level set, just do some baselining in terms of what the experience looks like holistically for beneficiaries and their families. So moving left to right across this vertical, it's probably no secret to anyone here that when asked to describe how folks generally begin their journey in the mental health ecosystem, it typically begins in a state of crisis. And folks are presenting in the hospital emergency rooms, working with Child Protective Services. There's been an incident that resulted in engagement with the local police department. Sometimes mental health care and treatment is being ordered as part of probation as a result of something like that. And then we have the two others down at the bottom where folks are self-identifying. So either family or individual is acknowledging that they need help and they're seeking care. And then we have folks who know that something's wrong and they're just not seeking care. And we're going to talk a little bit more about all of that in detail in the coming slides. After they enter the ecosystem, there's obviously this step of trying to figure out, what does help look like? What do they have for coverage and benefits? There's this sometimes formal, but often informal, figuring out how much family support is really there to be able to get the help that they need at the right level. They're often engaging with different types of providers, or stakeholders might be a better word. There are certainly providers, but there's also other things that they're juggling. So that's the medication management. They might be having to go through detox before they're going through the mental health treatment, working with their primary care doctor, managing their medications. And then working with others is just intended to acknowledge that, in addition, it's not just simply accessing mental health care, but it's managing all of those other stakeholders that are involved, like schools, the court systems, their probation officers, all of these other things that families are responsible for, or those adolescents are responsible for. So that's just really a baseline to say it is typically crisis when they enter. There is lots of managing and understanding that needs to happen, but it doesn't really end there because there's involvement with lots of other stakeholders. So moving on to the first insight we're going to talk about is really this notion of a fragmented ecosystem. There's no unified way for me to find out what's available for me and my family. And the story here is that families need simple and easy information. They need trusted resources and tools in languages they speak and know, and that it's important to know their early experiences with behavioral health are an indicator of how well they will remain engaged, or if they will remain engaged in that care-seeking journey or ongoing treatment that they need. So that trust factor is incredibly important. If they don't feel like that first experience was positive or helpful, they're likely not to return. There's lots of rules to navigate, particularly for families that are entering in crisis when intensive outpatient or inpatient services are needed. The policies that are required, the amount of days that they're allowed to stay, and where they can go and where there is a bed is complicated. An insight that is particular to Arizona, there is that added layer of complexity of the different systems that are available to them. So if they are living on reservation, they have I'm trying to think of the tribal healthcare system that they can use, and the options are a little bit more complicated. And the theme that we were hearing is that is not well understood by the folks who are supposed to be giving them instruction or advice about how to navigate that. So I think it's just going to call your attention to the quote in the bottom right-hand corner. What services can I get? How do I get them? And how do I find help? I don't know where to go, is pretty powerful. Moving on to access to higher skilled providers. Families report feeling like this process is happening to them as opposed to with them. And so parents are telling us they just want to find care for their kids. Kids want one-on-one. They think that they want this one-on-one treatment, so they're out looking for providers. And parents are looking for a diagnosis or some stabilization, right? If it's typically crisis and something is going awry, they want stabilization. They want to know what kind of a diagnosis that they're dealing with, and they want to get that care. The amount of there are providers, the wait times are pretty significant. And I think I want to just call out that the where do I begin is complicated. I know I can go and look for a provider, but I don't know what kind of provider to look for. When they do have a wait 6 to 9 months to get in for that first appointment, they will fall out of the system or have other interactions with some of those other stakeholders that I mentioned in the previous slide. Things are going to happen in that 6 to 9 months. So the notion of overusing the hospital emergency rooms came up a lot in our discussion with the community-based organizations and providers. Everyone feels like that is not the right use of the hospital emergency room, but it is the place where families can go to get care quickly. So thinking about those things, the last insight that I'll share with you in this bucket is there is a lot of providers, but there are not a lot of providers in what is described to us as in those higher skill sets in the mental health field. And we've had providers and community-based organizations share that they'd like to see more specialty services for adolescents. Families articulate that as, I want to talk to someone, I want my child to talk to someone who truly understands the nuances with teenagers. In the next insight here, avoiding teen crisis. Obviously, this is where folks are beginning. We don't want families and teens to end up in crisis. We're describing for you here what the crisis is a result of. So we talked about those long wait times for that initial appointment. The authorization process is complicated for folks, particularly for the intensive outpatient and the hospitalizations when they feel like that's needed. A lack of early identification and diagnosis. Many families are dealing with just a mental health issue. Some are dealing with developmental delays, and many families are dealing with both. So trying to figure out what is the problem here is complicated. And parents are simply not equipped to triage and troubleshoot or diagnose their kids. So the developmental disability versus the mental health crisis came up in multiple conversations because the modalities that are used to treat one is not necessarily right for the other and often requires different kinds of resources. But in the midst of crisis, it's hard to figure out what they need at that moment. So waiting a long time for those appointments is, or reducing that time is critical. Our next insight is around holistic family support. This is such a big one, and there's so much here. But the highlights are that when the adolescent is struggling, the family is struggling, and there's multiple things to call out here. So adverse childhood experiences, generational trauma, or generational substance use disorder are common in many of these families. So the children who need help are being parented by people who also need help, and maybe at different stages of readiness to talk about or acknowledge those things. So that's important. The positive thing is in talking with community-based organizations and providers, they all acknowledged the need and in some ways talked about how they apply trauma-sensitive or trauma-informed practices in their offices or at their place. We talked a lot and heard a lot about the different caregiver roles or the structures of families. So it's important for a solution to consider things like the family structure might be family of origin. Often these kids are in kinship care, they're in foster care, sometimes they're in residential treatment. So we have to think about that. We also need to think about the siblings and what the parents are struggling with. And so the families want to help their children who need all of these services, appointments, all of these discussions that are having to happen with all of these stakeholders, but they're still trying to manage a home and manage a family and figure out how to get them there. Transportation's an issue. They're just exhausted from all of the phone calls that they have to make and trying to get everyone where they need to be. The quotes at the bottom are really powerful. I can't leave work and pull my kids out of school and drive 2 hours to an appointment every week. And we heard a lot of that from folks who live in rural areas in both West Virginia and Arizona. And when I need help, I need it now. I can't wait. Because this is a crisis, not just for this teenager, but for the entire family. And then the last bullet here, we don't all have families that are able to or know how to support us. Just goes back to that very first statement that I made, that, you know, these kids are being parented often by parents who need help too. Our next insight is around cultural competency. So the theme here is, and I'm just going to call your eyes to the bullets on the left-hand side of the screen. In Arizona, there's a significant amount of mistrust in the healthcare system in general. Often families are multi-generational, and particularly for Native Americans and immigrant families. They just don't trust the system, and not just the medical system, but all of the systems that they might have to interact with. In West Virginia, the bootstrap mentality, which you see in quotes there, was shared with us. This is the notion that we can solve these problems in our home. The systems, including the healthcare system, is just perceived as intrusive. And there's a significant amount of pride associated with not having to access services, waving the ID card saying, I didn't have to use this. Folks are really proud of that. So there's lots of barriers here that will need to be broken down in terms of understanding the different cultures where people are coming from, and helping them feel enough trust that they can get that care. They want to see providers that look like us, but it's really hard to find them, particularly in those higher skilled areas of behavioral health providers. And in the school systems, we know that in West Virginia, they've got really strong school-based health centers. Those are still perceived as intrusive. However, they are more readily available in West Virginia. It's also, been shared with us that that's often the only place that some families are receiving care. So that I just want to call your eyes down to the quote on the bottom right. Appalachian people are proud people. They don't like asking for help. Asking for help for themselves is difficult. Asking for help for their children is one step further. And our next insight is around voice and choice. I think this is, I don't have much to say about this slide, except that it was really powerful. Some of the insights that we heard directly from teenagers saying things like, and I'm paraphrasing there for some of those quotes, you want us to be adults, but you don't treat us like we are. They want to be part of the discussion and part of the decisions about what happens to them. I mentioned earlier that it's happening to me as opposed to with me. They want to feel like their voice is being considered. They want to feel like they're being trusted when they're talking about where they are in terms of their healing or their sobriety. The Child Protective Services, is a big factor here when there's a crisis, whether it's at school or with the police. They're just not feeling like they're being heard. They feel like the adults are gathering to talk about them and what to do with them and where to send them and maybe what medication they have to take, but they really want to be part of the discussion. And our next insight is about care avoidance. So for all of the reasons that I've described in previous slides, there's fear, there's cultural beliefs, there's financial burdens put on families to get their kids back and forth to appointments, transportation issues, language barriers, impact to employment if people have to leave work to get these kids back and forth, the access issues. There's lots of shame associated with this, and then bad experiences that result in folks avoiding care. I want to talk about the fear on this slide for a moment, because there's a few things at play here. Child Protective Services is one of the things that we hear about consistently. We don't want them involved. We don't want them separating our family. Teenagers don't want to be the reason that their family has been separated either. So the parents don't want to get them involved or don't want them to be involved if they have been called for those reasons. Also for our immigrant families, they're worried about what their legal status being found out and what that might mean in terms of whether or not they could access care, or will that cause other problems for them. And then for families where parents are substance users themselves, they don't want that to be found out. And kids don't want their parents to be found out for those things either, because they know that it will cause problems for the family. And I just want to restate one of the first statements I made at the top of the presentation, is that those early experiences are indicators about whether or not they'll stay and remain engaged in ongoing treatment. If it's not a positive experience, they will avoid care. And that goes for, it has to be a positive experience for both the adolescent and for the family caregiver who's managing that care for them. And that is a summary of each of those key themes that we found in our insight. And I think I'm going to hand it back over to either Eamon or Carissa.